two psychiatrists rapping about our lives and work.
This podcast is not intended to be medical advice. Any stories we use have been altered to protect identities and sensitive information.
This is intended for entertainment purposes only.
You know it!
Ow! Welcome to the Good Drinks podcast, where we talk about our lives, work, mental health,
and everything in between.
That's right.
How you doing today, man?
I'm good. How are you?
I'm good. I've had a pretty good week. Got some time out with friends and got to do a little bit of listening to some music, some live music.
Oh, that sounds nice. Kind of rejuvenates the soul, doesn't it?
It does. You know, I was going to say that and I thought, soul.
You know what I've been listening to a lot recently?
Ooh.
I just got into it is, you remember the Donna Summer song, I Feel Love?
Yes.
It's like considered one of the greatest pop songs of all time, and it just...
That one?
Yes! I feel love! I mean, it's just like when you...
It's such a beautiful song.
It is. You can't help but be in a good mood when you listen to that song.
I mean, you might even say euphoric.
Yeah, to some degree.
Yeah. That's a symptom that we see sometimes with certain disorders that we deal with in the emergency room.
Yeah. You know, something I kind of want to bring up is this week I started therapy. You know, it was very vulnerable, but I think it was a good step in the right process. Just to kind of work through some of my own things and talk it out and feel how I want to progress moving forward. And I'm excited to start, to be honest.
Absolutely. I started therapy this year too, actually the end of last year, and it has been such an amazing experience. You know, getting to know yourself. Mm-hmm. How else can you deal with anybody else if you don't even know what you're dealing with?
Yeah.
It's I think, a very important thing to do. I recommend everybody get into therapy just to get to know yourself better.
Yeah, I agree. And you're kind of, even in that first session, like hearing like, oh, well, it sounds like, you know, there's parts of you that are conflicted and maybe a little bit of an identity conflict. Mm-hmm. And I'm like, okay, how long until I get a borderline personality disorder diagnosis?
Countdown starts now.
Yeah. But I mean, on that topic, right, I think a good topic today is often in acute crisis. Like, that's something that is very prevalent, that we see often in the emergency department, and distinguishing between bipolar, borderline personality disorder, and other mood disorders is something that we deal with regularly, and something that we can talk about today is kind of how we, from our own personal perspective, of how we go into the room and kind of make that determination to some degree.
So most of our job in the emergency room is trying to determine what's going on with people. You know, they're coming in. It's a crisis. It's an emergency room. So there's some urgency to what's going on. And you don't ever know what you're going to get into when you go into that room. So the first thing really is to just make eye contact with people, right? Try to build rapport and let them know they're in a safe place and they can talk about potentially volatile things, you know, with these strangers who are us, mm-hmm. Asking them these questions. Building that rapport is kind of that first step in getting to know them. And then, you know, we just ask a lot of questions. I think questions is how we get information, and that's how we start to figure out a diagnosis.
When we walk into the room, we use something called a mental status exam. And so that gives us an idea of the patient's appearance, how they're speaking, their thought process, you know, how linear or disorganized they are. You know, even from the second we walk into the room, it kind of can give us some perspective. Mm-hmm. And we kind of use that. It sounds maybe like we're being a little bit judgmental, but it's not. It's more of an observation of how the patient's doing. Because if someone comes in, let's say, very malodorous, like you can tell they haven't showered in several days, you know, where
hair's all askew.
Yeah.
Clothes, 3 layers of clothing on, you know, in the middle of the summer, or no clothing on in the middle of the winter.
Yes, walking around like, you know, found in a snowbank by police with like a bathing suit on. I mean, it gives you a perspective, right?
Absolutely.
And so we'll talk a little bit today about BPD and bipolar disorder. And just one thing I want to preface, this is not for diagnosis. This is just us as psychiatrists kind of talking about the disorders, giving our perspective of working with it in an acute crisis situation. But if you have concerns, please follow with a mental health professional to really make a determination, because there can be many other reasons for your symptoms. And so don't diagnose yourself by listening to a podcast.
Right. We're just here talking about our experiences, and we see a lot of different things. And it's very important, if you have any questions about anything we're talking about today, or any for yourself or for a loved one, to please reach out to a mental health professional and get some of your questions answered.
Yeah. Talking a little bit about borderline personality disorder, just kind of looking at statistics. There's some variability in both bipolar and borderline personality disorder, but it sounds like 1 to 5% of the population has potentially borderline personality disorder, whereas bipolar is a little bit lower. I think it's like 1 to 2%. So it shows that borderline is a little bit more common. They both have significant affect dysregulation. They're both serious conditions. Like an individual with borderline personality disorder can, 70% of those individuals could potentially have a suicide attempt in their lifetime. So something that, needs to be taken seriously. Maybe a way to get this started, maybe discuss like a general case, and we'll go from there. What do you think?
Yeah, let's talk about somebody that I met the other day in the emergency room. This was a lovely lady who was feeling pretty depressed. She had been working and going through some stressful things with her housing and financial situations, and she was just feeling pretty low. So she decided that she would talk to her boss about it a little bit, and then she suddenly had this outburst at work. She was assigned somebody to kind of show the ropes to at their place of work, and this person asked her a question that she took to be insulting, and she hauled off and slapped this person in the middle of their workplace, and then impulsively quit. Her boss, again, because they had talked before, realized something was up and said, "Why don't you go to mental health and talk to them, find out what's going on?" So she came in, she saw one of the first people to assess her, asked her a lot of questions, and she did endorse a lot of depressive symptoms. And then that person who did the first assessment came and talked to me about the case and said, "I think I'm just going to restart her on the antidepressant." And so I said, "Well, does she have any symptoms of bipolar disorder?" Because often we'll see people in the emergency room, and bipolar, as its name suggests, has two it's like a seesaw. So you have the manic symptoms on one side and the depressive symptoms on the other. But we might see somebody that is just in a depressive crisis and either never had manic symptoms before or just didn't think to bring them up. So it's very important that we ask those kind of questions. And so the person that gave me the report told me, no, they didn't really endorse any manic symptoms. So I was just going to put them on the antidepressant. I was like, well, let's go back and talk to them. So as we're sitting down, and maybe just to kind of throw it out there, what are some questions you might ask this lady to try to help you determine if this person might have bipolar disorder?
Yeah, so I think the big distinguishing factor, right, is determining if there's any underlying manic symptoms. So for bipolar disorder, you really look for discrete episodes of mania. Usually individuals have an inflated sense of self-esteem, a lot of grandiosity. They'll tell you things like they're starting businesses. They really just sound like they're on top of the world. It's almost like they believe they have superpowers in a way, like nothing can stop them. They're like Superman. They're not sleeping, pressured speech. They're talking very fast. They're hard to follow when they're speaking. It's just they go from one idea to the next, and they can't really maintain a coherent sentence. They're very distracted, and they often have tasks that they're trying to do. Sometimes when individuals start becoming manic, they will, in a sense, start tasks and decide like, oh, I'm going to clean my entire house, or I'm going to start some project, whether it's school or work or otherwise. And sometimes it's purposeless. Like sometimes they're just kind of frantically trying to do things. And then there's also risk-taking behaviors, gambling or spending a lot of money inappropriately, and not just sort of small purchases like, oh, I spent $20 more this week than I should have. I mean, emptied their bank accounts.
Right. Thousands of dollars,
credit cards, opened up new credit cards, bought multiple cars. and really just spend to the utmost of their ability to some degree. And then some people become very hypersexual. They'll become very promiscuous, even if it's not in their character, and really just engage in hedonistic tendencies. And
Well, euphoria and excessive irritability.
yeah.
I mean, you're getting in fights with people, like at the gas station. You're chasing them down the street. You're yelling. It's out of proportion to whatever the situation is.
Yeah.
Just excessively irritable.
And the irritability kind of we'll talk a lot about between bipolar and borderline personality disorder. The biggest thing with bipolar is, the episodes in bipolar 1 last for greater than a week. So it sometimes can last up to several months, but it has to be a week. And
Of these sustained symptoms.
of
that we're
sustained
talking about.
symptoms.
So this case, we went in and I sat down and we talked, and she pretty much had every symptom of bipolar. Decreased need for sleep. These are people who are not sleeping well, but they also don't feel like they need sleep. They're up doing project after project. Now, in their mind, these projects are getting done, but they're not. She was excessively irritable. She was getting into, this fight with this person at work over the person just asking them a question about how something is done. Very grandiose. She had all of these ideas of, different projects she wanted to do, that she was going to be the president of a music label. She was going to run for mayor in this particular town. She had all of these ideas. She did have pressured speech as we were talking, and she talked about having racing thoughts. And then she told us that she had a similar episode a few years ago. So all of these things sort of gathered, and I, again, just point out the importance of we could have sent that lady out with an antidepressant, which would have made it worse.
Yeah.
So asking these questions are just so important in helping us not only just understand, what's going on with the person, which of course is first and foremost, but also how to treat them, how to give them, some relief from what they're going through.
Yeah, and you kind of mentioned the antidepressant, right? Sometimes it can cause disinhibition and even lead to a manic episode in individuals that have bipolar disorder. And you kind of mentioned her having one episode before. So typically with bipolar disorder, you can go from depression to mania 1 to 2 times a year usually. If it's more than 4, then that's rapid cycling bipolar. And then something else too is if the manic episode isn't as severe, let's say they're able to continue functioning at work or school, but they're just kind of elevated and it lasts a little bit less time. So let's say 3 or 4 days. I mean, if that's the case, then we're looking more at
Bipolar 2.
Yeah.
So this particular lady, what was great was that we were able to kind of, again, it's a presumed diagnosis because you're, again, seeing people at one moment in time. And sometimes you don't know if you're leading, you're sort of asking questions, but you don't want to just assume that they're saying, sometimes they say yes because they want to be good, be a good patient, but it's not actually reliable. So again, over time is the best way to diagnose these things, not in a one-time emergency room, but you can get a picture for what's going on. It can help you guide your treatment plan.
I was going to ask you that, T. Why do you think, in some sense, from what you're telling us, so she had this dysregulation at work. Affect dysregulation is also a big thing in borderline personality disorder. What for you sort of made you feel it was more bipolar than borderline with that case? Because
she didn't really have relationship. Like one of the things I think about with borderline personality disorder is just like this trail of devastated relationships.
Yeah.
She didn't really have that history, so it didn't feel like I needed to go down that particular lane, especially once she started answering, yes to a lot of the bipolar questions. Decreased need for sleep. That's not something I necessarily see with borderline personality disorder. Grandiose ideas sometimes do see sort of an elevated sense of a person's self with borderline, but not to the extent that you see with bipolar disorder. I mean, these people think that they're Jesus Christ or Mahatma Gandhi or, these leaders.
Yeah.
You see some kind of sometimes transient psychosis, maybe some hallucinations or kind of they hear somebody talking to them or telling them to do things with borderline personality disorder. But with bipolar disorder, they're mostly delusions. You don't often see hallucinations with bipolar disorder. So the fact that she was answering so many questions with the, the decreased need for sleep, the grandiose ideas, excessive irritability, it looked more like the bipolar case. Also with borderline personality disorder, there's a lot of self-harm involved, and this particular person didn't have any history of self-harm or any suicidal thoughts. It's something you see quite frequently with people with borderline personality disorder.
Yeah, I mean, those are like really key points. Really unstable relationships, right? And it's kind of a chronic history of that. Like, just thinking of all the patients I've seen, like there's so many patients come in saying they're bipolar, had a fight with their boyfriend or girlfriend or spouse, and then all of a sudden they quote unquote become manic. They have a lot of affect dysregulation, but it's tied to something. Like bipolar, their manic episode happens for no reason usually. Like boom, it's like bam, next thing you know they're buying like Maseratis, But with borderline personality disorder, it's more related to a stressor. And oftentimes, individuals with borderline will say that their mood will fluctuate from mania to depression within the same day. And that's kind of more of a cue-in for me. It's like if you're having a lot of rapid mood fluctuations in a day and it's based on circumstances, then it may be more BPD. And
absolutely, I 100% agree.
Yeah, kind of fear of abandonment, right? So why are they so upset about the relationship and that argument? Because most people would like calm down, take a step back. It really is an intense fear of abandonment from their relationship because it has such gravity to them. Like really people with borderline personality disorder just feel more and can be very distressing to them because it's like, you want to feel, but like you don't want it to feel to the point where you're self-harming, right? Cutting yourself.
Your identity, your existence is dependent on this relationship.
Yeah.
A lot of times people with borderline personality disorder have had some kind of traumatic event, usually at a very critical part of, or time of their development. So they're developing a sense of themselves. They're developing an idea of, who they are in the world and who they should trust. And then some traumatic event happens. And so then that disrupts their idea of how to trust, how to believe. Who am I? Am I important? Do I exist? All of those kind of existential kind of questions happen subconsciously. So they're not like walking around asking themselves these questions. They're just having experience after experience it's informing them. Yes, you're right. This is somebody you can trust, or no, the last time you trusted somebody, they hurt you, so you can't trust this person. So all of that has to be sort of unraveled in therapy because the best treatment for borderline personality disorder is usually therapy.
I mean, you bring up a really good point there, interesting, like talking to one of our colleagues. It was kind of a dark joke, I guess, but we were talking about if you could just remove all trauma from children, it would really significantly reduce mental health issues like in adulthood because it really does, kind of carry forward. And, I was trying to find statistics on this. It said like 50 to 60% of individuals with borderline personality disorder have had sexual abuse. And they were kind of guesstimating, I guess there's like a little bit of a window there, but like 25% haven't, right? So then in a sense, why do they sort of develop borderline personality disorder? So it's not an end-all be-all, but I mean, it's a significant portion of individuals.
That's why I was saying just trauma itself, not necessarily sexual trauma. Any trauma at that time, the death of a parent at that time, that critical time. And it can be perceived trauma.
Yeah.
So it could not, like you and I might not think that it was necessarily traumatic, but that person, whatever was going on in their life at that time was significantly traumatic enough that it affected their development and their, understanding of who they are in the world. So yeah, the abandonment, the rejection. What else in borderline personality do we see a lot of?
The self-harm, right, that we mentioned.
Right.
Reckless behaviors, like sometimes they can use substance abuse as a method to self-harm. Reckless driving. I'm just sort of thinking for myself when seeing patients that have borderline personality disorder when they describe their mania, because some of them will say like, "Oh, I'm not sleeping, doctor."
And you could not sleep.
Yeah,
if you don't have a decreased need for sleep,
yeah,
that's the key.
And so that's when I kind of tease out. I say, "Are you taking naps during the day?" Because they may not be sleeping at night, but then they're sleeping
all day.
Yeah, during the day, or they'll go 2 days and not sleep, which. even someone without mania can struggle to do. But then I'm like, well, do you crash afterwards? And they're like, oh yeah, like I had to sleep. Again, they didn't sleep related to a stressor. They'll say they're like cleaning their house a lot, or just there's affect dysregulation for an event that happened to them. And individuals with borderline personality disorder, I mean, they really kind of gravitate to a person and kind of form their identity to some degree around that person. So if there is a collapse in that relationship, it's hard for them. Yeah, so tough. And something that borderline personality disorder individuals gravitate towards when it comes to a coping strategy is splitting. So it's like seeing someone as all good or all bad, right? Like T over here, she's never done anything bad in her life. She's all good.
Today.
Perfection. She better not wrong me, okay? But...
Borderline.
That's such a good song.
Ooh.
But, going back to splitting, individuals will see someone as all good or all bad. And so they idealize this person and, or devalue them. And so no one can maintain that level of perfection forever. Someone will disappoint you in some way because that's just the reality of the world we live in. Like, no one's perfect. It can be tough for them because they really do see someone as all good or all bad. Like, even when they're in the office to see us, they'll say, oh, the staff was so horrible, but you're so great. Like, it's kind of like a back and a forth. And I don't mean that in a negative way. I just think, like, from their perspective, it would be really hard because it's harder for them to sort of visualize or see the person as an entire entity.
They need to reframe everything.
Yeah.
That's the beauty of therapy.
Yeah.
It helps you reframe things that you've been through, and then you can assign different values to them. So yes, this traumatic thing happened. It devastated me. It's a loss. But what have I learned about myself since then? What can I do to heal that child or that person that, was hurt before? Because I'm not that person now. I've got skills.
And that's kind of a positive thing too, I will say, is I think over time, usually individuals with borderline personality disorder, they do improve, especially if they have treatment. Like they show a lot of improvement. But it's called dialectical behavioral therapy. The individual that actually started that form of therapy, she had borderline personality disorder. But she actually invented that style of therapy because she was so disappointed in, I guess, just sort of the general psychodynamic therapy or whatever form of therapy she tried before. And now it's like almost universal and working on coping strategies.
Very effective, very helpful.
Yeah. And I guess going back, talking about the song Borderline, I mean, that is kind of a bop, right?
Mm-hmm. And also, I was thinking about a movie that might outline what this looks like. I was thinking about that scene in Fatal Attraction where she clearly could not handle being rejected by Michael Douglas's character. And Glenn Close, who portrays that particular character in this movie, does such a phenomenal job of showing that sinister, kind of manipulative side to borderline personality disorder.
Yeah, 100%. It's such a good portrayal of borderline personality disorder. And, we kind of have the clip here. Maybe we'll play a little bit of it and give our perspective. What do you think, T?
Yeah, I think it'd be cool.
All right.
I don't know what you're up to, but I'm going to tell you it's going to stop right now.
No, it's not going to stop. It's going to go on and on until you face up to your responsibilities.
What responsibilities?
I'm pregnant. I'm going to have our child.
Alex, that's your choice, honey. That has nothing to do with me.
I just want to be a part of your life.
Oh, this is the way you do it, huh? Showing up at my apartment?
What am I supposed to do? You won't answer my calls. You change your number. I mean, I'm not going to be ignored, Dan.
You don't get it. You don't get it.
Don't you remember our weekend? Wasn't that wonderful? Why can't we just be like that again? I know you feel it too. I mean, what are you so afraid of?
Hey, just don't flatter yourself, Alex.
Go ahead, hit me.
Just...
What are you doing? Please, Dan. Please don't go. I didn't mean it. Please, I'm sorry. I'll tell your wife.
You tell my wife, I'll kill you.
It only takes a phone call!
Yeah, so that was very intense.
Yes. So parts of that she did not want to be. I mean, I will not be ignored. You're not going to ignore me. I'm going to manipulate you into getting whatever I want because this is how I show you I love you.
Show you my affection. Yeah.
It's very toxic.
I mean, even suggesting she was pregnant, in a sense, trying to bring him back in because she had fear of loss. This is really kind of interesting.
She idealized him and devalued him all in the same
breath.
Yeah, the same breath.
And also, obviously, someone like that too, she was a little bit elevated, right? She was upset. I mean, someone could come into the hospital and be like, oh, I had a manic episode with that, right? Because there was just such an intensity to that situation. Is there anything, I know it's just an audio clip, but is there anything, T, that you think she maybe didn't seem borderline to you? Does that make sense?
Is there something that stands out to you?
Not really. I mean, she portrayed it pretty well, to be honest.
Well.
I'm trying to think if there's anything specific that kind of stands out.
No, I feel like she had all of those characteristics.
The only thing I can think of is, did she threaten to harm herself at some point?
Not there.
Okay.
I feel like she cut herself or did something in the movie.
I think you're right. I think at one point she cuts her wrists. Yeah. I mean, she didn't quite get to that point of self-harm or suicidal thoughts. So, again, that's a pretty accurate depiction of what can happen. And the thing, too, is interesting is you see Michael Douglas in that movie is an affluent individual that has a family. But I think, this is just kind of a personal thought about borderline personality disorder. If someone idealizes you so much and the passion is so intense, you can see, in the early phases, how someone with borderline personality disorder can just, rope you in, and you will think, you're the greatest thing ever, and it's almost, probably intoxicating for the other person.
Yeah.
But, kind of maybe another media clip is we can show a little bit of mania and see what that looks like. So I think what we'll use is a clip from Homeland.
Claire Danes is masterful in this series.
She really does a great job of portraying it.
So, there you are.
Hey, how you feeling, Carrie?
Is it time yet? Are we going?
Going?
To work. We gotta hop to. We gotta haul ass to Langley. They have to understand Saul. Nazir's movements in green after fallow yellow, always creeping towards purple, are methodical, meaningful, momentous, and monstrous.
Okay, I'm gonna get you a bit more Ativan to settle you down.
I don't need to settle down. Tell him. I'll tell him.
Carrie, you're not yourself.
Of course I am.
No. I can't follow you. You're talking very fast. Your thoughts are running together. All these ideas. I can't understand.
It's pretty much on the nose.
I mean, one thing I will say watching that clip is, you can tell she's elevated and talking quickly and had some flight of ideas.
Disorganized thoughts.
She's amped up, ready to go do whatever it is that she feels they need to do. But I would say one small difference, T, is listening to her mania. When we see someone that manic, you can't even get a word in like he did to be like, I can't follow you. They're not letting you say that.
That's right. Pressured means you cannot interrupt.
Yes, the speech is pressured, and you cannot just be like, by the way, you're not letting me talk. But I mean,
right.
it's pretty accurate, right?
Yeah.
She's very euphoric, grandiose, right? To some degree.
Lots of ideas. Couldn't see her, but from the clip, she's kind of moving around very quickly in the room. Yeah.
Yeah, and maybe something too, that was just an audio clip, but she was fairly put together when it came to her appearance. And so when someone's that manic, usually the hair's disheveled, their clothes
they
are.
might have for the first couple days.
Yeah.
If it's just starting. But yeah, catch her in a week.
Yeah, and
she will be off to the side.
If he let her leave, she's probably going to go, she's purchasing probably heavier artillery, who knows at that point,
Or having an illicit affair.
Yeah, it's kind of interesting. And I think another thing, too, with bipolar is there are moments within the illness that quote unquote not exhibiting symptoms, like they're not depressed or they're not manic and they're functioning normally, which is a distinction from borderline personality disorder as it's more consistent.
And the people with borderline personality disorder, again, it is so emblematic, like you said, of the relationships that they're in. There's usually some stressor in a relationship that will usually push towards the self-harming or coming to see us in the emergency room. That's usually when we get involved because they've had some disappointment or loss.
Yeah. You know, do you think, just sort of thinking, a lot of individuals with bipolar will end up with a borderline personality disorder diagnosis or vice versa, right? Someone with borderline personality disorder may have a bipolar diagnosis. So from your perspective, T, why do you think that sort of happens so frequently?
I think sometimes people go to not see a psychiatrist first. And so if you go into, you know, your general practitioner and you're just talking about your mood, a lot of times, I mean, it might just be that particular practitioner thinks about mood disorders and automatically, you know, says that this is bipolar. It just comes down to looking at the criteria for those disorders and being very careful with your questioning. The duration of symptoms, that is really key in a quick, you know, if somebody is having symptoms for 5 to 7 days in a row, then you've kind of got that bipolar check boxed. But if they're just saying minute to minute, day to day, I'm always feeling like this, somebody said this, it made me mad, now I want to hurt myself, and this all happened in one day, that's not bipolar.
Yeah.
Has to be 5 to 7 days for a full manic episode, 3 to 4 days for a hypomanic episode. But still, you have all of those mood fluctuations, but it's the duration of symptoms. I think that's what gives you the best chance to diagnose it correctly.
I think that's what we do too. It's like, it's such an investigation because kind of even with this criteria, like while we're talking about it, it seems so cut and dry. But I mean, individuals, everything is on a spectrum. People present so differently.
And you don't always have that history about the duration of symptoms.
No.
That person that's manic is not able to tell you reliable information. You may not be able to get in touch with a collateral person. So sometimes you don't have all of the information you can to make a definitive diagnosis. So you might say, you have what we call a differential diagnosis. This is what it could be. These are the things we're thinking about. This is what we should follow up on. So then you put everything kind of in the bucket. Yes, this could be bipolar. This could be borderline. But we need these questions answered to be able to tell us for sure.
Yeah, and I think that's for us working in an acute setting. We don't really, we don't diagnose a personality disorder in one moment in time. I mean, really, it should be
You just get a picture.
a picture.
You get a sort of a visual, based on what they're saying and how they look and what they're telling you, you just get a picture. And that has to be followed over time.
Do you think, are there other sort of diagnoses that are common that mimic either bipolar or borderline?
Well, one of the components of bipolar disorder is distractibility or inattention, not being able to complete tasks. So often people with ADHD or attention deficit hyperactivity disorder can come in and have that attention span, and they're moving all around the room, they're hyperactive, fidgety, all of those things. And so that can sometimes look like bipolar.
It's really interesting you bring up ADHD because I agree. Like sometimes you see patients and the only thing that they're lacking is the lack of sleep. Like they're so fast when they talk. Their thoughts can be so scattered. They're very impulsive people, like you said. And they're just overall distracted. And it's like, man, they seem so manic. And then they're like, no, I'm sleeping fine.
Yeah.
I'm sleeping fine. And then you're like,
Not grandiose.
it's just severe ADHD.
Yeah.
And, it's important for us to know, right? Because it's a completely different treatment modality.
And there is comorbidity. So some people have ADHD and bipolar disorder. So again, it's just comes down to, do they check these criteria off?
Yeah, you're right. That's a good point, is comorbidity. Even just like looking at statistics between like bipolar and borderline personality disorder, apparently there's like a 20% overlap between diagnoses.
Yep.
So that's kind of interesting. And that can be due to a multitude of reasons. Maybe some of it that the symptoms are so similar, and then some individuals may have had the luck of the draw and ended up with both conditions. So that's pretty interesting. But yeah, I agree about the ADHD. It's so like fascinating seeing individuals like that, and it's like, man, it's just severe ADHD. Another one too is chronic PTSD or PTSD symptoms, because often they do have avoidance of situations, affect dysregulation, unstable relationships due to their trauma. But from my experience with PTSD, sometimes they almost like avoid relationships due to their past trauma to some degree. And then also the biggest one's like dissociation, right? Like they are not present in the moment. They have a lot of anxiety. They feel like their reality is not there, and they're just detached from reality. And individuals with borderline personality disorder often do dissociation that happens when things are very severe for them.
So don't you think that this really is just mental health wise a spectrum? It's a spectrum from PTSD to borderline to 'cause trauma being the source. It's almost like the trauma happens, you could splinter off into all these different things. PTSD, borderline, depending on when the trauma happened.
100%.
And then it's fascinating.
It really is. I mean, I think we sort of have our criteria and diagnoses, but there is so much like similarities and overlap between symptoms. Everything does feel somewhat on a spectrum.
Right. So even once you get this information, once we figure out, okay, we think this is leaning more towards one or the other, you still have to treat everything. You still have to meet the person, give them the information, right? So after we've collected this information, we present it to so this is what we found out. This is where we're leaning towards, and these are some treatment options that we have. What does the patient want? Why did they come to the emergency room that day? What can we do to really address their need? Because maybe they don't care that they have bipolar disorder. They just want to be able to sleep.
Yeah.
So...
Or not sleep, because think about it, if you're in full-time mania, you're loving your life, you're bar hopping, everyone's your best friend. Like, do you want to slow that down?
No, that's the issue.
You're like, let me go get another car real quick. But it's true, and so you're right. It does come down to
challenge.
Yeah, so it does come down to what the patient wants, and the paternalistic side of us wants to treat them like as we see fit, but it also is in what the patient desires. And obviously if they're manic and unable to maintain their livelihood, then that's an issue that needs to be addressed. And oftentimes those individuals come in from external sources, like family bring them in, or their workplace is like they're not functioning.
You were always battling the insight barrier.
Always insight. That's the biggest thing. And there's a lot of the times it's not there in the moment. And two, like even with borderline personality disorder, I mean, we treat the comorbid symptoms that they're having in relation to their mood. I mean, they can have very significant depression, anxiety. We often do treat them with mood stabilizers to try and just help with affect regulation. I mean, there's things that also need to be addressed. I mean, obviously, or maybe not obviously, but with borderline personality disorder, therapy is the staple. That's the mainstay of treatment long term. That's going to help them. But giving medications along the way can have a significant impact.
Help with impulse control, sleep, appetite, all of those things. Yeah.
ADHD, you give them a stimulant, they may be a new person. All that kind of ties together. And I kind of like this topic because I enjoyed treating all three of those things.
I mean, they have actual symptoms that we can look at and get information about that this might be what they're going through, and then there's a treatment that can help, and then you watch them get better.
I agree. I think it's like interesting to see in person, and I think that's for us it's kind of maybe why we have some perspective, just because we see it so often in the emergency setting and just like how we view it and want to treat it. And it's interesting because I'm sure a lot of individuals have their own experiences with mental health and how they perceive their treatment at the time. But we really do kind of work towards helping others and kind of using our experiences to help guide them in the right direction to the best of our ability,
Absolutely.
So, yeah.
So, any other interesting things about borderline or bipolar you want to bring up?
Well, maybe not a specific case, but a general trend I notice is there's a lot of kids that come in showing symptoms of depression. Self-harming often begins around the age of 12, right? I'm not saying it's necessarily completely tied to borderline personality disorder, but the affect dysregulation is sort of apparent at that age. And just like from my experience, I think back, there's so many different theories in mental health, right? Even the origin of borderline personality disorder. Is it like a two-hit hypothesis? Is it someone susceptible to that condition? A trauma happens and then it manifests in the person? Is it a genetic link? Could just be some other factor in the environment. So there was a child psychoanalyst back in the day. Her name was Mahler. when we talk often about like the terrible twos, so that is a time when kids want to start exploring their environment, but they're too scared, so they need their parents close by. So in like psychology, we call that being the stable base. And the kid will come back to the parents to like recharge, and a psychological term for that is rapprochement. So and one of the theories that's accepted is maybe parents around the terrible two age may not have been a very solid base for that child, so they became more anxious and had difficulty controlling their affect at that age, and then that kind of was what persists throughout lifetime. And it's just a theory, but I really do kind of like that theory to some degree, because I think really our early age, like 4 and below, it has such an impact when we're older, and it's like that kind of makes sense to me, like a reason that might be happening.
Yeah, again, you're just trying to figure out what's going on in the world, and who am I, what's safe, what's not safe, who do I trust, who do I not trust. It's fight or flight survival instincts back then. You're just trying to figure everything out. I mean, you're trying to figure out how to talk, you're trying to figure out how to walk, you're doing all of these things. Your brain is in high gear. You're forming connections and associations to all of this stimuli around you. So of course, anything traumatic that happens during that time has a major impact. Again, it could splinter off into different things. It could be bipolar. No. It could be borderline. It could be PTSD. It could be dissociative identity disorder. It could be any number of things.
Yeah.
It could be nothing. It could be that you just resolve that conflict later on in life and never have a disorder.
Yeah, that's true.
That's what's fascinating too, is that if you look side by side of these people maybe going through the same thing, some people develop. So I think that is more evidence for your two-hit hypothesis, that it is not just some genetic thing, like something has to happen.
Yeah, it's just you're not quite able to have that resiliency for whatever reason, and then
It's so complex, we'll never be able to say, okay, it's because you didn't have the XY gene there and the CP3 gene over here. And
it's very even like kind of researching a little for this, like with bipolar disorder, they say a lot of times like the limbic system may be dysregulated, which kind of controls your autonomic nervous system, and then there's all these theories about like the body's response to emotion. But really, even like looking through it, I mean, there's theories, but we're not 100% sure. The brain is so complex. And maybe speaking on that, last week when we were doing our episode, I was working overnights. So even it's interesting because I have a second degree family member that has bipolar disorder. So I was like editing that episode and listening. I was talking a little bit fast. Like maybe I was a little bit, maybe I was a little hypomanic.
I mean, those night shifts, they
wear you out. They really do.
I mean, no, they can definitely elevate you. Like
Yeah.
I've had episodes or times that I've worked overnight, and then a couple days after that felt like I could do anything.
You have a little euphoria.
All this little energy, and then I completely crashed.
Yes, it is.
Several hours later.
It is documented. There is like people do become hypomanic when they don't sleep, and in the initial stages, you get like a little bit of a euphoria boost.
So is it that the mania is causing the decreased need for sleep, or is the decreased need for sleep causing the mania?
Exactly. The chicken or the egg.
Right. It's all mixed up in there.
Well, anything interesting this week for you, T? That
I start my overnight shift tonight.
Ooh, here we go. So
yeah, 2 nights coming up.
Everyone get ready. Next week, T is going to be unhinged. I'm here for
More
it.
unhinged than normal. No.
Well, sounds good.
Yeah, we'll see you next time.
See you next time.
Bye.